agenda, we're going to talk a little bit about what the research shows about the prevalence of burnout and the consequences of burnout and the drivers of burnout. And then we'll pivot to some of the solutions that have been popping up, the bright spots around the country. And I want to start with a couple of takeaways. And the first one is that while burnout manifests in individuals, it originates in systems. And so it's really important when we think about our solutions to burnout that we think about not individual solutions, or at least not just individual solutions of yoga and mindfulness, as helpful as those can be, but we think about what are the systematic changes that can make a difference in terms of burnout. So we've been monitoring the rates of burnout in partnership with researchers at Mayo and at Stanford since 2011. And so every 3 years we do the standardized survey and we find out what the rate of burnout is among physicians. When we did it in 2020, in the fall of 2020, we were really curious to see what the rate of burnout would be in that first year of COVID. And we found that burnout rates that had been 45% among physicians back in 2011, went up to 54% in 2014, dropped in 2017. And what would they do in 2020? They actually dropped. That was unexpected. But I think we can understand it in that the experience of COVID was very different across different specialties and across different regions. Not every region had their biggest surge at that point. And it was a time of great meaning, stepping up to the plate, working together with others, meeting the moment. So we decided that that was probably not reflective of the second year of the pandemic. And so we did an off-cycle survey, a national survey using the same methodology, a representative survey. And we are that's just been submitted for publication, and the rates went up to the highest they've ever been, at 63%. And on the plane here, I was looking at some of our additional data to write up in another paper. And our physicians who are in COVID-facing specialties, emergency medicine and critical care in particular, have exceedingly high rates of burnout at 80 and 70% respectively. And professional satisfaction has plummeted. And in those fields, it was about 12 to 15% of the population was endorsing feeling professionally satisfied. And these numbers are despite the fact that physicians are more resilient than the general population. So the problem with high rates of burnout has nothing to do with any kind of resiliency deficit. We don't need to fix the worker, we need to fix the workplace. So as I've thought about my 32 years in practice and what's happened over the several years since I've left clinical practice, I'm aware that when the electronic health record was introduced into our practice, so I worked 16 years with a paper record and then 16 years with an electronic health record, and 2 different records during that time. And I saw how the EHR created so much more work for the nurses and the physicians. And also how there was, we talk about the Great Resignation, but what I recognized looking back was when we introduced the EHR and the way it was introduced, it was this great work transfer. That work that previously was done by the receptionist, the ward secretary, the pharmacist, the transcriptionist, all suddenly became the work domain of the physician. And that led to cognitive overload, it led to time pressure. And so we studied that time pressure. And with researchers at Dartmouth, we trained medical students to do time motion observation of physicians in 4 specialties, 4 states, 7 different EHRs. And the bottom line of that was we found that physicians were spending 50% of their workday on the EHR, which translated then into, for every 1 hour of direct face-to-face time with patients, there was an additional 2 hours of EHR and desk work. And despite that, despite spending 50% of the workday on the EHR, our physicians were taking 1 to 2 hours of EHR work home at night, work that's been called pajama time. So another study, so that was direct observation. Another study from the University of Wisconsin used audit log data from Epic in this case, and they looked at 142 physicians over a 3-year period of time, and then they validated those findings from the audit log data with direct observation. And they again found that 50% of the physician's workday was on the EHR.
And of that 6 hours a day, 4 hours was on work that I would consider does not need a medical school education. Order entry, billing, coding, documentation, processing refills. Most of that can be done by a team. There is a peak in physician time on the EHR on the weekends, but of course we know that that's not the best way for our physicians to be restored, to be having date night with their EHR. Well, then there's this issue of the inbox. And the issue of the inbox has been an issue for many physicians for a number of years. But it has become a crisis over the last couple of years. In fact, for our team, for the work that I lead at the AMA, we have chosen the inbox as one of 2 priorities that we are working on in this year. And it's a cliche to say that people don't leave their jobs, they leave their bosses. But I would say for physicians don't always leave their clinic, their hospital work, their patients, they leave their inbox because the inbox has just become unmanageable. That study from the University of Wisconsin, this was pre-pandemic, found that physicians were spending 1.5 hours per day on inbox work. Much of that is just getting rid of rote messages. For family physicians, that's 100 inbox messages a day. That was pre-pandemic. Well, this is data looking at the entire user base of Epic. And when you look at the entire user base and look at the type of inbox message called patient medical advice request, you can see that at the onset of COVID, there was a spike, 157% increase in the volume of inbox messages, and that has persisted. So telemedicine also went up. Telemedicine visits have come down a little bit, not back to where they were, and probably rightly won't ever come back, but the patient medical advice requests have stayed at this very, very high level. But there's been no compensatory change in the other work responsibilities for our physicians, and so hence more of the time squeeze. So this is also pre-pandemic data. Part of this comes from a researcher, Julia Adler-Milstein at UCSF. But what she found was that physicians who have the highest level of inbox volume, the highest quartile, having over 300 messages per week, had 6-fold higher odds of burnout compared to those who had 150 messages per week. And again, remember that the average family physician pre-pandemic had 100 messages a day. She also found that those in the top quartile had 13-fold higher odds of burnout compared to those who only had 30 minutes of work outside of work in the week. So that's some of the baseline data that we have around the drivers and burnout. Let's talk about the consequences. And I think if you care about patient safety, you have to care about professional burnout among our physicians in particular, but also among the other health professionals. The data for physicians, we know that when we're burned out, we are twice as likely to make mistakes. There is data that gives a patient safety grade 2 units, and there's 7 different grades. If you are in the highest, the most safe unit, but you are burned out, so you're in the A-rated unit, but you have burnout, your patient safety is equivalent to a D-level unit. So we've invested a lot in patient safety, and I think that's really important. We have not yet invested equivalent amounts in terms of reducing the drivers of burnout for our physicians, and yet it has significant consequences for the safety of the care that we deliver. Patients are also less satisfied. There's twice as many complaints, for example, around their physicians who are burned out, and that of course makes sense. No one wants to be cared for by someone who is experiencing burnout. For physicians, there are personal consequences, higher rates of disease, of drug and alcohol use, misuse, and divorce, death by a variety of means. And for organizations, higher rates of malpractice, 17% higher rates of claims among the physicians who experience burnout compared to those who do not. Turnover is higher. Longitudinal data from both Cleveland Clinic and Stanford have shown that if you are burned out at time X, 2 years later, you are twice as likely to have left the organization. That is really costly for the organization. So we did some work. T. Chainefeld and I worked with Joel Gohl, who is a health economist. He was at the Harvard Business School at the time, using published data to estimate what the costs of burnout are. And this was very conservative, looking primarily at the cost of turnover to the organization. And so we published that in JAMA Internal Medicine, and then at the AMA we converted that into an interactive calculator, so you can go online and put in how many physicians in your organization, what your local rate of burnout is, and if you don't know, we pre-populate it with the most recent published data on burnout. And we've put a very conservative cost of $500,000 per physician who leaves. We know that that cost is probably considerably higher, some estimates of over $1 million per physician who leaves. But using conservative estimates, you're a group of 1,000 physicians, you are already investing over $10 million every year on burnout. You're just investing it at the far end and replacing those physicians who leave. If you invest a fraction of that upstream, you will have a great return on investment. We have a return on investment calculator as well. So then we also looked at it from the perspective of the payer. And there's data around the cost of a primary care physician leaving to the payer. And we used that then to estimate that there's $1 billion of excess healthcare expenditures. The patient going to the emergency room rather than in to see their physician, patient being referred more to other care providers. That costs $1 billion a year to the U.S. healthcare, to payers in the U.S. healthcare system. And about a quarter of that is turnover that we can attribute to burnout. So we also looked at COVID stress and work intentions, because the rates of turnover we fear are going to be higher as the pandemic goes on, and physicians who could step up to the plate and really kind of be there, you can't do it continuously. You just can't do that as a steady state. And what we found in the first survey is that 30% of both physicians and nurses intend to reduce their work hours in the next 12 months. 1 in 5 physicians and 2 in 5 nurses intend to leave their current practice within the next 2 years. We know from other data that about 30% of physicians will act on that intention. Childcare stress resulted in an 80% increased odds of burnout and a 91% increased odds of intent to leave. That was across all healthcare workers. And feeling valued was protective. If you felt valued by your organization, and this isn't by having an ice cream bar or muffins, but by actually being prepared with PPE, with training, with support, feeling valued, that was protective against both burnout and intention to leave, 60% lower odds of leaving. So let's turn to some solutions, and I like to present solutions on the Stanford WellMD model because I think it's pretty simple and memorable. The idea here is that professional fulfillment, the inverse of burnout, is driven by organizational culture, practice efficiency, and personal resilience, although I restate that latter as institutional support for individual self-care, because I think there's a lot institutions can do to make it easier for physicians and others to care for themselves, to be sure they take vacation, that they're really on vacation when they're off. But we're going to focus on the top two, the systems drivers, and practice efficiency is the one we'll spend the most effort on. And it's my observation that in most practices and in most settings and most specialties, physicians can save between 3 and 5 hours of time every day. How? By re-engineering the way the work is done, by eliminating unnecessary work, and by more strategically delegating work to an upskilled team. At the AMA, we've created a wealth of resources. We have over 75 practical, actionable toolkits on how to do some of the practice fundamentals to save some of that time. And then we've created playbooks. So we have the Taming the EHR playbook with a variety of different topics and pointing to some of the toolkits. Then we have webinars and we have podcasts on the topics. Things that should not enter your inbox. And one example is patient event notifications. And so there's just a lot of things that just clog up the inbox. And if you're intentional about it, you can remove that, and that makes a big difference to practice efficiency. Another issue is to have sufficient support. The least functional model is the doctor does it all model, where the doctor's in the room with the patient, and the whole issue has been designed around actually the doctor and the computer. We only don't think about the patient. But if we can support that physician so that they can spend the majority of their time giving undivided attention to the patient, the outcomes for the patient are better, for the clinic are better, the financial outcomes are better, and for the physician. Well, this is Dr. Jim Jerzak from Bellin Health in Green Bay, Wisconsin. And at Bellin, they were also one of the next-gen ACOs. And so they piloted their advanced team-based care model with 2 upskilled MAs per physician. And in their physicians who were in this new model, compared to their physicians who were still in the traditional model, they found improvements in their performance measures, so their quality measures, in their patients' likelihood of recommending. They saved $27 per member per month in their ACO, and they also brought in more revenue to the organization by having more care gap closures, more mammograms, colonoscopies, that sort of thing. So with Bellin, we sponsor a team-based care training camp every year, although we've put that on hold with COVID. And one year, a group from Intermountain came to learn about advanced team-based models of care. They went home and they went right to work, and they put together what they call their Working Smarter model. They had 2.5 MAs per physician. And they collected some data and shared that with me when I was there visiting. So they had baseline data on number of patients seen per day and the documentation time per day. Then they came to the training camp. Then they went home and got back to work with their pilot. And then by the end of a 6-month period of time, they had the capacity, they were seeing 20% more patients. So a lot more revenue to come in to support that additional staff. Their documentation time per physician had dropped by 20%, their burnout dropped by 50%, and time on orders dropped. Now this was a very small pilot, but these are the numbers that we are seeing across many organizations, that they are saving time. Most organizations find they need to see 2 more patients a day to cover the cost of that additional staff person. UCLA did this as well, a slightly different model, but same idea. And what they found for their internists and their geriatricians is that they were saving 1.5 hours of physician time for every 4-hour session. So every day they saved 3 hours of physician time per day. They also had significantly improved patient satisfaction scores for their patients who were in that model, and they published that in JAMA Internal Medicine. This is the University of Colorado, where they train the residents in this advanced model of team-based care. And in this model, the faculty also get that model, and they found that burnout rates dropped in half after 1 year in the model. And although they didn't require that their faculty see more patients, they, at the end of the year, were seeing 3.5 more patients per day. So greater access, greater revenue generation, and greater physician satisfaction. So with that, let's switch to organizational culture. And I want to tell you about something else we do at the AMA. We've created what we call the Joy in Medicine Health System Recognition Program. And the purpose is to recognize organizations that are further down the line in terms of taking clinician well-being seriously. But it's also to give those who haven't yet started on the journey but who realize that they need to do something around professional satisfaction, to give them a roadmap. And so we have 6 different domains of activity, and we have criteria within each domain and 3 levels of achievement. And I'm just going to focus on one under leadership, which is to appoint someone and begin to de-implement unnecessary administrative burdens. And we're very specific about the kinds of things that you can do. In fact, we provide a de-implementation checklist, and anyone can access this. All of this is online, free. You don't need to be an AMA member, no username, password. And we ran this de-implementation checklist past the Joint Commission, made a few modifications on their suggestions, so we know that everything here is aligned with Joint Commission standards or requirements. And one of the items is to decrease a password revalidation requirements. And so I got an email from Dawn Clark, who's the Chief Wellness Officer from Kaiser in Southern California, about maybe 2 months ago. And she said, I'm so excited, we did this. That item on your de-implementation checklist, and it's going into effect tomorrow. We are no longer requiring physicians to put in another username and password, even though they're already signed into that patient's record. We're not requiring them to do that again anytime they change a medication in the record. Then she sent me an email about 2 days after it went into effect, and she said, my neck is no longer sore from doing the badge login. I'm no longer doing as many username and password entrances. And they calculated that they affected 1.5 billion orders per week with this within their system. So it just tells you what we can do if we make an effort. In Hawaii, getting rid of stupid stuff, Melinda Ashton wrote the article in New England Journal. And in there she says, everything that we might now call stupid was once thought to be a good idea. And I think that's true. But many of those good ideas are no longer relevant, and it's time to reconsider them and start doing more de-implementation. So the Joint Commission's really been a good partner with us. And they said, you know, organizations, they frequently set the bar too high for themselves. We don't set the bar as high as they are, but if they have a policy, our goal is to make sure that they're consistent with the policy. But then the Joint Commission gets nicked for seemingly being the source of that. So they get scored as out of compliance when it's really that they actually created a policy that they did not need to. So to help with that, we've created a Debunking Regulatory Myths initiative at the AMA. And so we have, I think now, maybe 12 myths. And then we go to the federal, wherever it is in federal documentation, to debunk that myth. And then there's a PDF that a physician or anyone else can take to their compliance office and say, hey, you know, everyone says the Joint Commission requires this, but they don't. Or everyone says that CMS requires this, but actually they don't. And here is the documentation of that. I wanted to end with a restatement. We've heard of the quadruple aim. So we know the triple aim is better care for individuals, better health for the population at lower cost. The shortcut to the triple aim is to focus on health professional well-being, so that fourth aim. And Catherine Lucy, a colleague at UCSF and on the American Board of Internal Medicine Foundation board in the past, restated this once, and I'd like to end by sharing her language for the quadruple aim. Care, better than we've ever seen. Health, better than we've ever known. Cost, we can all afford. Delivered by professionals who find joy in their work as they commit to serve others. And that's a vision I can sign up for, and that's a vision I believe collectively we can come closer and closer to meeting.